Oh, you don't, but all right. Okay, so tonight we're going to be talking about resuscitation. What did you guys learn last night? I get to capture me. Okay. You guys don't remember what you learned last night? Cardiac, right? Okay, so tonight we're going to be talking about resuscitation. So what's that mean to you guys? Yeah. So what we're talking about is resuscitating the patient, whether it's airway, breathing, circulation, taking care of one of those things to get them back, or it's just taking care of the heart. So last night should have been talked to about how the heart works, right? Starts as a pump on the top, SA node fires, constricts the atrial, forces it down to the ventricles. Ventricles then contract, forcing it up into the pulmonary artery where it gets oxygenated, or through the aortic artery, which then goes to the body, right? Okay. So how is the heart fed its oxygen through all these little arteries and veins here? Did Stacy go over that? No? Okay. So as it gets pumped out into the aortic artery, or aorta, there's a couple little ports that go to the veins of the heart. So as it pumps out, it's also being pumped all the way around the heart. Okay. So you got your, right descending artery on the heart, your left descending artery, and then circumferential artery that goes around to the back of the heart, feeds the back of the heart. So without blood flow, without oxygen, the heart dies. The heart's dead, the body's dead, because it's no longer pumping oxygen to the brain. It's going to take a little while for the brain to die, but once it dies, the whole body's dead. Okay? Make sense? All right. So, we're going to talk about pathophysiology of cardiac arrest, patient assessment, and improving cardiac arrest survival. Those are the three things we're going to be covering in the 83, 84 slides that we have. All right, so pathophysiology of cardiac arrest. What do you think this is? Yeah. So the right side where that arrow is pointing is where the clot is in the heart. This is before PCI. The one on the left is after that clot is removed and a stent's put in there. Okay. You see the difference in the blood flow? Okay. Immediate relief. Okay. If this isn't taken care of, it turns into a heart attack. Okay. It goes from heart attack to cardiac arrest. Let me just get that right. Okay. All right. Functions of the heart is to pump blood. So it's just basically a big, huge pump that squeezes. Every time it squeezes, it pushes blood somewhere. You know, it's either to the lungs or to the body. It has to have significant pressure behind it to get all the way around through the body. And it has to have the right electrical current to fire off the muscles in the heart. So that SA node, if there's a failure in the SA node up here, then the message gets interfered with, doesn't quite make it to the AV node. The AV node's going to take over, and it's going to start firing down through the septum to the Purkinje fibers and out through the heart. Okay, it's where we get our ventricular rhythms, is when that's just firing, because it's not enough. It's not getting any information from the SA node, or the SA node's not firing right. It's not constricting the top, so the ventricles are just firing. So it's still going to get some of that ventricle or that atrial blood every time it fires, because when it fires and releases, it's going to suck and it's going to pull some of that blood down, but blood is not going to be sufficient to keep the body going for very long. Yeah, it requires oxygenated blood. That's why that picture back here is so important. This guy probably started feeling chest pain because the heart started dying in the areas that weren't getting blood. Then once they opened it up, that area starting to get blood, starting to revive that section, that ischemic section again. Yeah. All right. Mechanical failure. What are some causes of mechanical failure that you can come up with other than the ones that are up there, or even including the ones that are up there? What is mechanical failure? Yes, yeah. So what causes the stopping, right? So think of your vehicle. It's out of gas. Is that a mechanical failure of your vehicle? Yeah, can be. Throw a rod in your truck. The mechanical failure of your vehicle. Yep. So any kind of loss of normal heart structure. So basically, blood supply gets cut off, heart starts dying. It's no longer going to pump as efficiently. It's mechanical failure. Myocardial infarction, same thing. Chronic hypertension. Why would chronic hypertension be an issue for it? Fatigues the heart, yeah. Loss of normal heart valve function. So later on tonight, if we got time, you guys can listen to my heart. I have a very distinct heart murmur. So you guys can figure out what that sounds like. Direct trauma. We talked about this. What was it called? Cardio something. I can't remember the name either. So. Yeah. I'll come back to that one. Yeah. Anyhow, direct hit on the heart. Oh, yeah. Yeah. Comedial cordis. So a direct hit to the heart. And remember, it's, where do we do with our, okay. So we got our P wave, our QRS, our T wave. That T wave is our reset of the heart. So that's where the heart is resetting and returning to a polarized state. If something hits on top of that repolarization at the peak of that T wave, it can stop the heart. It'll stop the repolarization section. And then you don't get any beats. Okay? Cause the heart go into fibrillation, VTAC, or it could go into asystole. Pulseless electrical activity indicates that there is a mechanical failure. Why do you think that indicates a mechanical failure? Anybody? Bridger, why do you think there's a mechanical failure in pulseless electrical activity? Right. Right. So there's still an electrical charge there, but there's no mechanical effect. So something's gone wrong with the heart, and it's not beating, but there's still electrical activity going on there. Good. All right, electrical dysfunctions, cardiac conduction pathways, coordinates electrical conduction. We just talked about that, the SA node down to the AV node, down to the bundle of his, down to Purkinje fibrils, out to the heart, okay? So fibers out to the heart. Asystole is a complete failure of the electrical system and the mechanical system. And disruption of electrical functions generally results in a dysrhythmia. So there'll be some kind of dysrhythmic activity going on there. When we talk about bundle branch blocks, I don't know if thought I heard Stacy say something about that while I was here last night, but A bundle branch block is basically an interruption in electrical activity that's causing some kind of dysrhythmia of the heart. Yeah. Okay, so your dysrhythmias, what do you want to know about the patient? About their heart rate? Daryl.
What do you want to know about their heart rate?
Yep.
If they had any things put in due to surgeries.
Okay.
If they have a history of heart murmur.
Okay.
Whether their rate is usually fast or high.
All right. So it's a good thing. Knowing what their normal is. Okay, that's a very good point there. So if you've got someone who runs marathons all the time, their resting heart rate might be 54. Okay. If you have someone who's in AFib constantly, their heart rate might be between 90 and 120 all the time. So you're going to see them high, you're going to see them low, back and forth. So yeah, very good. Ventricular tachycardia, what do you want to know about this rate? There's two types of ventricular tachycardia. Did you cover it last night? Okay. Anybody going once, going twice? What do you think? Yeah. Yeah. Well, what do you want to know about it? So people can have a pulse with ventricular tachycardia and be talking to you. Okay. So before you go putting the pads on because you see ventricular tachycardia up there, make sure they're unconscious and don't have a pulse with it. Because if you do, your AED is going to read that as ventricular tachycardia, not that they're awake. And it's going to tell you to shock them. So that might cause them to really get amped up if it's telling you to shock them. And if you shock them, they're going to be really pissed off at you. So, and you might send them into defibrillation then without a pulse. So ventricular fibrillation, heart's just sitting there quivering. There's nothing really going on. At least with ventricular tachycardia, it's pumping, but it might not be doing anything. It might be that electrical failure where it looks like it's pumping, but the mechanical portion of it's not working. So, any of these dysrhythmias can lead to sudden cardiac arrest. So, it's too slow. They're not getting enough oxygen circulating to their brain. Eventually, something's going to say, yeah, we're not getting enough oxygen. They're going to stop working. If it's beating too fast, it's not able to perfuse properly. It's not refilling totally before it pumps again. Same thing. It's not getting oxygen to where it needs to go. And eventually something's going to wear out and stop. VFib and VTAC are correctable. Most of these are correctable in one way or another. But VTAC, VFib are the only two rhythms that your AED is going to shock. So understand that. I believe that will show up again on a test, either in class or on National Registry, but just know that VTAC and VFib are the correctable ones that you can shock and hopefully get them back. Yeah. Oops, that was the wrong button. Sudden cardiac arrest, abrupt onset of dysrhythmias. So dysrhythmia is any abnormal arrhythmia. So once you see something that doesn't look right on the monitor, you don't have to interpret it. Do a 12 lead on them, send it to the hospital, let the doctors take a look at it, and they can figure out what to do once you get them in. Okay. If you see something that's odd and that you don't know how to treat, you're on a basic service, this is a load and go. You're going to get them into the hospital, you're going to get ALS intercept if you're a long ways out, and you're going to get these people into where they can be treated. Talked about acute blunt trauma, so that could be anything: baseball to the chest, bat to the chest, the magic kung fu heart-stopping punch, any kind of. Hmm? And on the commotio, yeah, it is commotio, not commotion cordis. Oxygen levels are relatively normal at the beginning, but you will see them start to decline as the dysrhythmia goes on. Okay. Why do we think that the oxygen levels are going to decline? I haven't I called on yet. Go. It's smart. Hmm? So why would we expect the oxygen levels to decline if they're normal at the beginning of a dysrhythmia? Right. Yep. So if the heart beats too fast, it's not pushing all the oxygenated blood all the way through the body, right? So if it's beating too slow, it's not getting enough oxygen through the body. So your perfusion rate is going to slow down. Start seeing that cap refill start to slow down. Who was on with us the other day that I was asking about that? Was that you? They asked you about they pushed it on the skin and let it go. And it took like 5 seconds for that blanching to come back to being red. So you can use that as an identifier of perfusion, even on adults. It's not as reliable, but if it's taken 4 or 5 seconds for that blood to come back into that skin, you have low perfusion to that area. Asphyxial cardiac arrest. What's that mean? Suffocation, right? So something's interfering with the oxygen delivery system, and that oxygen is not being passed through the body as efficiently. And now that oxygen going to the heart is decreasing. It's going to start causing your dysrhythmias. Once it gets to a certain point, they're going to have chest pain. Bam, they're going to have go into cardiac arrest. It's where you're sudden cardiac arrest. So asphyxial, heart stops pumping due to systematic hypoxia. Usually takes a while for the heart to start dying as it's losing that oxygen. Let's see. Good. Yeah. So with kiddos, a lot of their cardiac arrest issues come from low respiratory arrest. Usually, if a kid's in cardiac arrest, it's because they went into respiratory arrest first. So, what are you doing? Okay. All right. This usually appears with more warning than sudden cardiac arrest because they'll have that chest pain. If it's due to respiratory arrest affecting first, they'll have that difficulty breathing. You'll usually get called for the difficulty breathing. That's something that we can correct. So if you can get that corrected in time, usually can be counteracted and you don't go into the cardiac arrest. Your quality of ventilations during CPR on these types of arrests are very important. Okay. And we've talked about this quite a bit throughout the class. This is a primal reflex. It's just basically the body getting any kind of air it can. These are death respirations, agonal respirations, whatever you want to call them. A lot of times these people are already in cardiac arrest, but it's the body trying to get some oxygen into itself. So that hypothalamus is being stimulated, and it's just trying to get whatever it can into it. And don't swallow. This will end in death unless someone intervenes. So this is where we get talking about trying to get community to do CPR. Getting CPR out to the community type stuff. All right, fixes cardiac arrest. Heart fails to pump, blood stops moving, cells are robbed of their essential oxygen and nutrients. What are the two things that the cell needs to create ATP? Glucose and oxygen. So if it's not getting the oxygen, it's not getting the glucose, cells are going to start dying, organs become damaged, eventually they'll fail. The organism will die if uncorrected. What is the organism in this case? The body, the patient, right? So if you don't get enough oxygen, you don't start correcting these issues with oxygen, they're eventually going to die. So the goal is to intervene as early as possible. So when someone's telling you they're having difficulty breathing, even if they're talking in what appears to be full sentences, understand that does not mean they're not having a respiratory emergency. George Floyd is a perfect example of that. George Floyd had high amounts of fentanyl in his system and was screaming at the top of his lungs, "I can't breathe." Okay? Non-medical person would think, well, he's screaming, he can't breathe. Obviously, he's breathing. But his respiratory system was being shut down by the amount of fentanyl he had in his system. It wasn't corrected, and he died. So your goal is to intervene as early as possible. Listen to your patients. They might be speaking in full sentences. They might not. So look at what's going on with your patient. Listen to their lung sounds. Listen to their breathing. Check the pupils. Make sure they're not on opioid drug. Pay attention to what you're seeing with your patient. Don't just take in and go in there with a biased assumption. Okay. Okay, cardiac arrest in children are generally asphyxia. We just talked about that. So causes choking, shock, respiratory problems. A lot of kids out there nowadays with asthma, that is pretty severe. So when you're seeing these cases, understand that children their cardiac arrest can be usually fixed if you fix their respiratory arrest issue. So breathing for them. Children actually have a higher success rate of resuscitation when it's caught early. Okay. Okay. Time is it? Okay, we got a few minutes. Okay, patient assessment. What do we know about patient assessment? What's our primary assessment consist of? Sorry for that squeak online. Yeah, so life-threatening injuries, which are, okay, severe bleeding, massive hemorrhage. What else? Think about what do you do in your primary assessment? What's your focus? ABCs, right. So, or if you want to go with whatever those long things Brandon was going over, you can go over March. So massive hemorrhage, airway, respiration, circulation, and then back to, is there any minor bleeding that's going to cause them to bleed out? Head injuries, stuff like that. Okay. So
on that note.
Okay.
On your skill sheets for your medical station, does it make sense when you are treating an actual patient to be simultaneously getting secondary assessment or getting blood in the real world? Does that make the sense? Okay. National Registry wants to know that you know how to recognize and treat a life threat first into your airway breathing. Once your airway breathing and circulation is done and you have recognized for, do I need to see spine? Do I have any major bleeding? And I'm going to titrate some oxygen on my patient. By all means, after that, you can start your history taking of your OPQRST, your sample, and then go on into your vital. And if the sample and the OPQRST and the vitals happen at the same time, props to you, you're knocking it out of the park. But do not do any of that stuff before you clear your airway breathing circulation. You will fail your medical.
All right. So what are we looking at when we're checking the airway? Yeah. So is it open? Do they have an open airway? Are they talking to us? Are they breathing? That. What do we want to know about their breathing? Yeah. Is it too fast? Is it too slow? Is it of good quality? So if they're breathing, taking in nice deep breaths, we're not worried about it, right? If we can hear wheezing from across the room, are we concerned about it? Yeah. If we hear stridor from across the room, we're very worried about it. That means the airway's closing up. Circulation, what do we want to know about it? Cap refill. Basically, we're going to check pulse, we can check radial, we can check carotid. We want to know, do they have one? Does it feel fast? Does it feel slow? Is it bounding? Is it thready? We're not worried about how many beats a minute we're getting. We just want to know, do they have a pulse? Okay. And is there anything that we need to correct on that pulse? So when you get your ABCs on your stations, and basically in the real life, you know, there's a lot of times I'll just come up to someone, say, how you doing? My name's Jim. Can I help you? Okay, they got a pulse. I don't even care how many beats it's meant happening. I want to know, does it feel fast? Does it feel slow? Or does it feel like it's a good heart rate that's getting blood circulating? Okay.
If they have a radial pulse, what is that?
Their BP.
You have a radial. What's a normal heart rate supposed to be? 60 to 100. So if they have a radial pulse, are we within that range? Typically. Right? So that means we're perfusing.
Yeah. All right, so some of you have been through this because I know Tyler and I covered it with you. What is a BP around? What do you know their at least their systolic blood pressure is if they got a radial pulse? Yeah, about 90. What if they just have a carotid pulse? About 60. So that's the only two we're going to be worried about. They don't have it here. They're at 60 here. 60 is not a sustainable life blood pressure, okay? So we want to start getting ALS going, getting that patient moving, all that stuff, okay? All right. Perceptual narrowing, focusing only on the patient. What's that mean? Yeah, so getting tunnel vision. Use situational awareness. Be aware of your surroundings. Don't just get focused in on your patient. You go in, BSI scene safe. The officers have already been in there. You go in, you start talking to your patient. Right next to your patient is a firearm. Okay, is that a safe location for you to be? Okay, you don't know how this patient is going to react to you. Even if they're calm at the beginning, they may not be calm at the end. So, you know, be aware of your surroundings when you go in. And you go into some of these places and there's cat poop and dog poop all over the floor. Watch where you're kneeling. Dirty needles. You know, is this a drug user? Is this someone who is diabetic and they just give themselves a shot then throw it on the floor? You don't want to get stabbed with a dirty needle. So be aware of your surroundings. Okay. Primary assessment, identifying three key features of cardiac arrest. Not responding to you, not breathing, and they don't have a pulse. Cardiac arrest is identified. Once it is identified, you're going to immediately begin chest compressions. You're going to have your partner go get whatever else you need, and then go from there. Okay? Our cardiac monitors, if for some reason you come to work for us and there's a rodeo going on and it's Bradley and Afton down at the rodeo that day. It's a basic truck. You can turn our cardiac monitors into AEDs by simply pressing one button. So once you press, there's numbers down here on the bottom. It says 1, 2, 3. Okay. Once you press analyze,
Attach pads.
it's going to tell you to attach pads. Okay. Once you attach pads, it's going to read the rhythm. See if I can get out of this now. And it sees this rhythm, which hopefully you can all see it. Does that look like a good rhythm? You can see it? Yeah. 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 So we got, I think it's AFib going across the monitor right now. It's going to read that. Then it's going to tell you to go on to the next step of an AED. Okay. Once paramedic gets on scene, they can take that now. They can adjust it. If it was me, I would leave it in AED mode and just start going about my business. I'd adjust the charge as I needed to, and then take all commands from it. Because it's going to tell me when 2 minutes CPR is up, when the next vitals check is due, stuff like that. So, all right. If you have an AED like the one our trainers, it's going to walk you through the steps. So
I don't think ours talked to us, but the one.
this one does. Because I've accidentally done that. Hit analyze. Analyze.
Not all.
Maybe. No, I've had it talk to me. I mean, it doesn't like tell you at the end of 30, but at the end of 2 minutes, it'll say analyzing patient. Oh, yeah. Yeah. No, I don't think ours do either. All right. 3 commonly reported types of sudden, oh man, now they made it complicated. They threw a U in there. Sudden, unexpected, infant death syndrome. Okay, 3 commonly reported types of SUD is sudden infant death syndrome. So SIDS, there's no reason for it. They can't find a reason for it. They just died. Another one is unknown cause. And then the third is accidental suffocation or strangulation in bed. Okay. Mother rolls over on the child, doesn't realize it, ends up suffocating it. Child gets tangled up in blankets and ends up strangling itself.
I watched a set of parents. Baby was lying on the bed on its belly, felt like this. They each picked up a side of the blanket, bent the baby in half, backwards, like not intentionally or hard, whatever. So they were taking the baby up off of their bed, put the baby in the next to the bed. They didn't want to wake him up. Bent baby. Baby's on his belly. Puppy blanket. Terrible idea.
All right. So for some reason back in the 90s, this was a very common thing. I think education has gotten parents better at supporting their child's back and, kind of cradling the child in the bed so that it can't roll over to its stomach. But there are children that prefer to sleep on their stomachs, and they will find a way of doing it. Mine was that way. It's probably why he talks so much now. So yeah, typical patient, cardiac slowdown, sleep apnea. So these children basically, their hearts slow down, they stop breathing at night, eventually stop breathing altogether, and it doesn't start again. The episode will be fatal. The infant is not reached in time. Majority of the cases that I've been called on this, they put the child to bed, woke up the next morning, were surprised that the baby slept through the night, went in to find them purple rigor set in. So there was no resuscitation done on those children. Unless rigor mortis set in, try to provide some kind of resuscitative efforts. Even if it's just for the parents at this point in time, to get them their headspace and timing back to normal, thinking you did all you could, knowing that you did all you could, and then you're going to provide emotional support for the parents. You're going to hold any thoughts you have as to whether or not this was intentional or not until you are out of view of the parents and you talk to the doctor or law enforcement. Okay? You're going to provide support to the parents the best you can. Okay? All right, let's take a quick break. Be back at 7:35. I'll give you 10 minutes. All right, so we're going to talk about improving cardiac arrest survival.
Let's preface this by saying there are new standards. They're probably not going to meet the requirements of this book.
Yeah, we'll correct them as we go through.
So if your book says something and Jim or I say,
All right. So 2025 standards came out last year. So as we go through this, we'll correct whatever is missing from your book. So 5 elements: recognition, activation of an emergency response system. Where do we know this from? Yep, BLS. Immediate high quality CPR, rapid defibrillation, basic and advanced EMS, advanced life support, and post arrest care. They actually have a 6th one that goes for out of hospital or recovery now. So
I knew it started with an I was walking past it.
yeah, so recovery and post cardiac arrest care is now its own little link in the chain of survival. Teamwork and coordination are the keys to a successful arrest. Okay, or a successful code. I guess successful arrest would be that they die. So we don't want that to be the success rate. So working as a team, if you guys go on a cardiac arrest here, I know the firefighters in the room have been on a few with us. Things work very smoothly in the midst of chaos. Okay, everybody knows what they're supposed to do. Everybody follows directions, so it works out really smooth. I've been on cardiac arrests with both on the fire department and on EMS, where afterwards I'm looking at everybody going, okay, how did that go? And they're like, that was totally foobar all the way through. And I'm like, no, it wasn't. Well, we did this, 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 and this. And we can bring them back to, hey, yeah, sure, the cop tripped over IV line as he was going out the door and pulled the IV. But we got another IV, or we got an IO, or we did something. Things happen in these arrests, but knowing how to correct the problem is where we become successful. So as an ALS crew, if you're on with us during this, we are going to work the code until we either get ROSC back, this return of spontaneous circulation, or we call it. Okay. Everything we do in the field is what's going to be done at the ER. Okay. If we get into the ER and we say we've done 5 epi, 4 lidocaine, we've given sodium bicarb, calcium gluconate, we've done all this stuff, the doc's going to probably work it for about 5 minutes and call it once we get in. So we've gotten to a point where, at least if you're on with me, the only thing I transport are children, and that's only because they have a higher rate of coming back, and then we can do more, we can work them longer, and we're probably going to get them back. With adults, once we've exhausted what we can do in the field, there's not much more the hospital is going to be able to do for them. Okay. So a lot of times we'll get on phone, call medical control, let them know, hey, it's what we've done. We're going to go ahead and call it. They're good with that. Okay. All right. Efforts must begin before arrival of EMS. This is where you need to be talking to your family members, your friends, and getting them to go through some kind of CPR class and learn this stuff. Because if someone collapses in front of them and they begin CPR, they're going to have a higher chance of survival, even if all they're doing is hands-only CPR.
3% chance survival.
I don't know, last things I read on it were 10% chance of survival. If it started right away, it goes up to 15 to 20%. So the earlier they recognize that it's cardiac arrest and begin resuscitation, the faster, the higher, more likely they are going to be to survive it. I'm having a hard time talking today. Dispatch, all our dispatchers, I believe, are now trained to do EMD. That's emergency medical dispatching, where they will walk someone through how to do CPR. Okay. And as EMTs, it's kind of one of your, not really a duty, but it's something that you should be doing, is getting the community to participate in CPR training. Okay. I've brought it up with the hospital a couple times about putting on free classes, stuff like that. They always say they're for it, but I have yet to see one be done. But hopefully that's something that we can work into in the future. Okay, link 2. Guess focus a little more on this. Recognize. Can you read that for me?
Sure. Recognize cardiac arrest.
Yeah, recognize and activate emergency services. Get that done, 1. That's link 1. Link 2 is begin immediately high quality CPR. So getting that CPR going. What it does, maintain cerebral and cardiopulmonary perfusion. So it circulates the blood throughout the system. You got about 5-10 minutes worth of air that you can circulate that's in the body in that dead space. Remember, we were talking about dead space during the airway classes? There's still oxygen in that dead space. So as you're doing CPR, that's circulating that oxygen. As you're, even in hands only, if you can maintain an open airway, every time you pump, push down on that chest and release, creates negative pressure within that system. It's drawing some air into the airway too. Okay. So maintaining that oxygen going to the cerebral and coronary areas is very highly important. Keep the brain alive, keep the heart alive, they have a better chance of survival. Okay, hand placement. Lower 2/3 of the patient's sternum. We teach in between the nipple line, but people's nipples change depending on their age. So just right middle of the chest. Heel of one hand in the center of the chest, heel of the other hand on top of it. So you're gonna grip it like so. And you're gonna use your body as a pendulum, kind of force that chest down. Children, the same as the adult. What they're teaching now is you can either do two-handed or one-handed, and that's pretty much the way it's been for a while. Infants, they're no longer teaching the two-finger compression technique, is the palm of your hand. So you're gonna put the palm of your hand in the center of the chest and you're gonna compress. Or you can use the two thumbs encircling technique still. I like the two thumbs encircling technique, works pretty good. But if you're the only one there, it's a little bit harder to switch to the breathing. Compression depth on adults is about 2 inches. For children, it's 1/3 of the chest, so pushing 1/3 of the depth of the chest. For a child, it's usually still about that 2-inch mark. For infants, about 1.5 inches. Okay. All right, for adults, hands should overlap, interlock fingers. Some of the stuff that I've walked in on when people are doing CPR, they're doing two hands across the entire chest. Probably not going to get that good compression of the heart and that refill. Your pivot point should be about your waist, not the elbows. You're not pushing down on them. You're rocking down on them. So think of an oil derrick, whatever those things are that go up and down. Little dinosaur looking things, pumps. Yeah. So if you think about a pump, it's got a point here that has a rod coming down, goes into the earth. But its focal point, bending point is back here. So as it goes down, it's bending at that point there. So that's what you want to be doing. Elbows should be locked. Weight over the shoulders. Press no more than 2 inches. Or press no longer than 2 minutes and switch with another provider. There are going to be times where you're the only one there and you're going to be compressing for more than 2 minutes. How many people have done CPR in this room? Okay. Anybody done it over 2 minutes? You get tired after a while. I think the longest, yeah. Longest compression I've done was from Esterbrook down to the hospital. It was, by the time I got relieved, it was 90 minutes compressing. I really don't think I was compressing all that good towards the end of it. Once we had someone else to relieve me, I had them take over because I was tired. So you'll find out it does get tiring. And don't be the hero on that. If someone says, hey, you need a break, say, yeah, jump out. Get that break, okay? So you can see here, not going to show up there, is it? Nope. So elbows are locked, hands are interlocked, up to the shoulder, shoulders over the arms, down. The pivot point is fulcrum at the hips. Okay. And starting, if we get done early enough tonight, you'll start getting a lot of practice on this, okay? So starting probably, when do we start skills nights? 2 weeks?
When do we?
Yeah.
Or like when we have like.
Yeah. Might be the 11th. I think it's like in 2 weeks. Yeah. So our skills nights will be that. Expect to be here the entire night. Okay. We are going to have stations set up around the room. March 3rd. Yeah. So starting March 3rd, we'll have skill stations set up around the building. You will go to each of those skill stations. Yeah, these are not times to be screwing around. Okay. Focus on your sheets, focus on the skills that you're learning, focus on doing it right. If you fuck around, I'm sorry for using that kind of language over the air, but if you mess around doing this, when it comes time to take your practicals, you're not going to take it serious. You're going to fail your station. Okay. If you fail more than 2 stations, we will not be able to redo that day. You will have to do them another day, which means you will have to go to another school to do your stations. Okay.
Not the whole school.
No.
Care Solutions out of Quebec doesn't have their cycle the other day until June 31st. That's your next cycle order day.
Yeah. Because the state is going to be the one that sets up the time. Okay. So understand you need to take these skill stations seriously and you need to work them. We will give you a scenario. You have 3 people in your station that day. Each person switches out and does it. And you'll go on to the next station. You have your times are listed on the board. That is your goal. For the month of March doing our skill station, you'll be able to use your sheets. Starting in April, you will not. Okay. So, all right. Yeah. That was my squirrel moment. All right. So compressions, 100 to 120. Doesn't matter who you're doing them on, child, adult, infant. It's going to be 100 to 120 beats a minute. Okay. Compress too slowly does not generate enough cerebral coronary perfusion. If you go too fast, it doesn't give the heart time to refill with blood. So you want to make sure you're going at that 100 to 120. You're allowing the chest to come all the way up. You're not short stroking it and not allowing that heart to fully perfuse. Okay. Minimize the pauses. We have, what do they call that? Cardiac compression fraction, something, CCF fraction, that every time you pause, it takes the heart a little time to refill, to get back up to where it's fully pumping blood. So you want to limit that to no more than 10 seconds, preferably less. If you've got 2 people doing CPR, 1 person doing breaths, it shouldn't take more than 3 to 5 seconds to do your 2 breaths. You're not breathing 2, 3, 4, 5, 6 like that. It's 1, 2. Okay. You're just giving the bag enough time to refill, and then you're pressing in your second breath. Then they go back to compressions. Should be nice and quick. Okay. Yeah, we just talked about it. Take steps to avoid pauses. So we'll talk about, that's what, we'll bring it over later. The auto pulse. It talks about it in the class. But so we'll talk a little bit about why we use the Lucas and the auto pulse here in a minute. But the main thing is you want to make sure you're doing those compressions and you're limiting the time of delay in between them. Make sure you clear rescuers during analysis. One of the reasons is I've never seen it happen before, but if you don't totally clear the patient, it could pick up on your rhythm and give you a false reading on the AED. So make sure you clear the patient. If it says that it needs to charge, you can resume compressions at that time until it's charged, and then once it's charged, stop compressions. Okay, pre-plan your compressor change out. So yeah, if Bradley's doing compressions, I'm going to tell him, hey, next cycle, next rhythm check, We're going to switch out with Bridger for compressions. Okay, and then Bridger's going to take over on that next rhythm check. Rhythm checks should happen about every 2 minutes or 5 cycles CPR. When you're doing your station, expect to do 5 cycles of CPR. Okay. Can't remember what the book said about that, minimizing urgency of transport in initial phase. But I think it has to do with just work the patient for a little bit before you transport, okay? Train as a team in realistic situations. So supposed to do meg codes every little while. Do you have a question or was that a stretch? Okay, that's all right. Just want to make sure I'm not missing a question. Okay, you can stretch, just make sure. Okay. Yeah.
Research has shown that the shorter the time between the last compression and shock delivery, the better the chance to drop. Minimizing interruptions requires practice and coordination, especially between respiratory freedom and compressions and respiratory operations.
Yeah. Yeah. Okay, Trina's team, like I said, we're supposed to do meg codes a couple times a year. Sometimes we do, sometimes we don't. But it is important we get enough CPR in the field, usually that as a team, EMS, fire, law enforcement, we work really well together. So train with tools of resuscitation. So train with tools you're going to be using. So, all right. Rescue breaths, ventilation. Ventilation should be 2 ventilations every 30 compressions. Pediatric and children on 2 rescuer. So that's another change to the book. So children and infants, you're going to do a 2 to 15. So 2 breaths every 15 compressions. Okay. And that's on your 2 rescuers. So that's the difference. 1 rescuer all the way through, it's 30 and 2. 2 rescuer for child and infant is going to be 15 and 2. Okay. Then follow your local protocols for ventilations. That's whether or not you're going to do continuous CPR and ventilate every 5 to 6 seconds, regardless of what's going on, or if you're going to do this. Our protocols are whatever AHA says, and that's the 30 and 2, 15 and 2, until you get them tubed. And that's going to be continuous compressions, 1 breath every 6 seconds. Okay. All right, so mechanical CPR devices. We currently use the Lucas CPR device. We used to use the AutoPulse. I think they might still have one up in Glen Rock. I'm going to try and get it down here. If they do, that way you guys can look at it, see what it looks like. It does not take long to put these devices on. Less than 10 seconds if you plan it out right. We'll stop CPR, put the back portion underneath, have them resume CPR while we're getting the top portion ready. Once we get it ready and we're ready to apply it, stop CPR, apply it, and it usually takes probably 10, 15 seconds to get this thing on with minimal interruption to CPR. The stabilizing straps, those are the little straps on the hand. And then there's another one that goes around the neck and hooks to the device, prevents the device from sliding down. Then whether you call it or you get spontaneous circulation back, you're going to then turn off the device. Okay, you don't want it to keep pressing on someone's chest who's already circulating at a good rate. Okay. So usually we have the IV done before we do the straps.
That,
And the reason you want to power it down is you don't want to be loading them in, have that accidentally get pushed and resume doing CPR on someone who's already back. But you don't take it off them necessarily because there is a chance they're going to rearrest. Okay, Zoll Auto Pulse. So I guess I should describe these things. So the Lucas device has a plunger in the middle of it, has a suction cup to it, comes down, presses onto the chest, and it does compressions that way. It's just like doing compressions with your hands. The Auto Pulse actually has a strap that wraps around the chest, and when it compresses the whole chest. Okay. It's kind of a neat device. Like I said, we ran them here. I've had 2 saves using the Auto Pulse. You're going to provide mask ventilation, the rate 2 breaths every 30 seconds. After 2 minutes CPR, reassess shockable pulse. So it's just basically the same as how you're going to be doing CPR any other way. The Auto Pulse, again, has 2 settings. It has a continuous setting and a 30 and 2 setting. And these do not work on infants and children, small children. So you got to be aware of that. With those, you're still going to be doing manual CPR. I think the Lucas was no children that's like 8, I think. It's either 8 or 12 years of age to use it on. And I believe it's the same with the Zoll. All right, link 3, rapid defibrillation. To achieve successful resuscitation, the heart must begin pumping again, which means it needs electricity, okay? It needs to disrupt whatever electrical things are going on there that is causing the disruption, whether it be VTAC or AFib or VFib. So you're going to deliver a shock to correct this dysrhythmia. Okay. AED is 2 devices in one. It has a sensor that recognizes those 2 rhythms. And then once it recognizes them, it'll automatically charge itself to a preset rate. So depending on whether it's biphasic or monophasic, will depend on what that shock is. Monophasic shocks give a shock of, 200, 300? I think the first shock is at 200, second shock is at 300. The biphasic ones shock at 200. Yeah. Is that right? I think that's right. We haven't used monophasic. That could be. Okay. Yeah. So anyhow, there's a set rate that they're going to shock at. Okay, most common conditions resulting in cardiac arrest are shockable rhythms, which is VFib and VTAC. I think we're pretty much beating this one. So what are your 2 shockable rhythms? VFib and VTAC. Good. All right. Monitor looks something like that. We've been using the blue ones that look similar. 2 types of AED. Oh, there we go. Monophasic, biphasic. Sends single shock from negative pad on one side to the positive pad on the other side. Biphasic sends one in one direction and then it returns in the other direction. Okay. Basic life support keys in cardiac arrest survival, quality compressions, and rapid defibrillation. Those are the things you should be taking out of this portion of it. You need good compressions to make sure the blood's still circulating. You need to get them shocked back into a pulsating rhythm. AEMTs, paramedics can provide advanced procedures and medications. Really, the medications are good. What saves the patient are those first two things: quality compressions and electricity. Okay. Triangle of life, one provider delivers compression, another provider attaches AED, one provider manages the airway and delivers ventilations. Ideally, a 3-person crew is what you want. Okay. Team leader may add advanced life support outside the triangle if additional providers are present. So basically, my job as a paramedic is not to get involved, but stand back and tell everybody what to do. Okay. Doesn't happen that way because usually we don't have enough people with the higher skills to get in and do that. So if it's paramedic bus like me and Tyler, JJ and Cher, we can sit there and one of us will do an advanced skill for the airway while the other one's doing drugs. And then we'll kind of switch positions and move around and kind of guide everybody else.
Here's what's really happening. Jim and JJ are fighting for the 2, and I'm down putting the IO.
Never happens.
No, because you don't let us do the machines here.
I think someone got a king tube one time.
I did.
All right. Okay, coordinating numerous means of assessment and intervention that together maximize the chance of neurological intact survival. So link 5, advanced life support, post-arrest care. So this is for if you're on a basic bus, is getting them to an advanced crew or have an advanced crew meet you on scene or getting them to the hospital. So getting them into the hospital, if you're down at the rodeo grounds and something happens, transporting them straight to the hospital instead of waiting for ALS might be the quickest way to get them to an ALS provider. If they're across the street over at the courthouse, definitely just bring them over to the hospital is going to be quicker than waiting for us to get on scene and do stuff. But know your times. If you're 20 miles out on 59, calling Life Flight, calling ALS, that's what's going to save your patient on top of the stuff we've already talked about. Recognize the return of spontaneous circulation. The heart's beating on its own again. How will you know that? They have a heart rate, right? So you're going to tell that by what? How are you going to tell if they have a heart rate? Checking the carotid pulse, right? When we're doing CPR, we're always checking carotid. The funny thing is, if you want to know if CPR is being done correctly, check for a carotid pulse while CPR is being done. You should feel a pulse. Okay. Recognized by the patient starting to breathe again. Okay. You're sitting there bagging someone. Afton disappeared. So, oh, okay. So what'll happen is if you've got that good seal on that mask, when that person starts to breathe, you'll feel that bag get weak. And when they do that, that means they're starting to breathe on their own. Okay. You want to know how many times a minute they're breathing at that point. So you can, if you feel that bag get weak, just give them a little extra breath. You're going to do that for a few minutes, for a couple of cycles, just to make sure they are getting good oxygenation. Okay. Okay. Initiate immediate transport, appropriate hospital, manage airway, blood pressure, ventilations, contact ALS. Definitely have suction ready, especially if this was a basic resuscitation, because if you don't have that advanced airway in, air has been going down to their stomach. So once they start coming to, they're breathing on their own, they got a heart rate, they may not be conscious yet, but expect that stomach to start spasming, everything, that all that air coming back out the top. Okay. And obtain 12 lead and get it sent into the ER so that they can interpret it. All right. So question came up earlier about placement of 12 lead. So when you think about placing the 12 lead, your arm leads are going to be on, or your limb leads are going to be on the limbs. Okay. If you look, sometimes people place them on the chest, on the abdomen. You're going to get a better reading if you place them over the top of the shoulder and down past the hip. So if you can get them on the limbs, that's the best place to do it. So 2 on the chest, V1, V2. You're going to go in your 4th intercostal space, down. Okay, so it's just going to be right above the chest. Okay, these are the ideal placements. You're not going to be able to place them like this on every single person. But V1, V2 go 4th intercostal space. V1 goes on the right, V2 goes on the left. V3 is going to go right below V2 in the 3rd intercostal space, or 5th intercostal space. V4 is going to be the 5th intercostal space also, straight down, crossed. V5 is going to be on this plane that's, can't remember what it's called, this plane. So you got your midclavicular, that's about where you want V4 to be at. And you're going to have V6 be on your mid-axillary line. And then V5 is going to go in between it. And you want it ideally 4th intercostal space, 5th intercostal space. Now, a lot of times you're going to have to go a little bit lower on females because of breast tissue. You might end up in the 6th intercostal space. But what that does is that gives you the best reading of the heart, okay? And you're looking at the heart from 12 different directions. The only place you're not going to see is the right side of the heart and the posterior of the heart, okay? Does that answer questions on limb placement, lead placement? Yeah. All right. Let's see. Management of cardiac arrest. Perform 1 rescue or team-based CPR. Use standard precautions. Don't get gunk on you. Wear your gloves. If you got eyewear, protect your eyes. Use an automated external defibrillator, whether it's the monitor in AED mode or an AED itself. Always request ALS when it's available. In this state, ALS is always available, okay? Whether or not they can fly to you will be determined by weather condition. But you can always call for ALS no matter where you're at. Even if there's a basic service in Lusk and they're this direction, they can call for us and we'll intercept with them. Same with Glendo. Use bag valve mask device with oxygen. You can, on initial contact with the patient, use a bag valve mask without oxygen. In your oxygen station on BVM, they actually have you do that. Now, that you don't get docked points if you hook it directly up to oxygen and start bagging them that way. But you got to be able to do it within the time frame that's required. Okay. Any questions over this so far?
Can you pause?
Yep. Hold 1 second, please.
Fine. Oh,
Where do you want it? Okay. Where did we get these from?
because donating it to the fire department.
Hold. Okay. Cool. All right. Back to our regularly scheduled programming. Okay. Lift and move patients. Suction the airway. Use airway adjuncts. What ones do we use? OPAs and NPAs, correct. And interview bystanders or family members. If you, whoa, I lost my balance there. If you have the ability to ask questions, in other words, you have enough people there that you're not just focused on doing CPR, and you can find out what happened. Was it a witness arrest? Was it unwitnessed? Does he have any heart problems? If it's a drowning, you know, how long were they down? All this stuff. So interview bystanders, find out what their medical history is, get your ample sample history from them if you can. Switch roles as compressor to avoid fatigue. Be sure you have appropriate personnel on hand. BLS and ALS care is what works the best. Facilitate teamwork. Assign a team leader. Team leader is going to be your most experienced medic on scene. So if it's between Bradley and Bridger and they're running the call, Bradley has been doing a little bit longer than Bridger, so Bradley's going to be team lead. Okay. Probably not going to have much time for a pre-resuscitation huddle, but as you're going to a call, you're going to be talking about what you're going to do once you get on scene. That's your pre-resuscitation huddle. It might be that you get on scene, bystanders doing good CPR. You might take a second, look at everybody that else there and go, okay, this, you're doing this, you're doing this, you're doing this, I'm doing this. And that's going to be your pre-resuscitation team huddle type thing. You're going to assign everybody a job and have everybody do it. All right, let's take a 10-minute break. Be back at 20:30, and we will continue on with steps of resuscitation. Oh.
What it is that you guys.
All right, we'll go ahead and try and finish this up. So steps of resuscitation. Steps ensure the key elements of cardiac arrest care are provided. Sequence may be different depending on the resources available. Failure steps to meet the needs of the situation. So we talked earlier about use of the Lucas device and the auto pulse. According to AHA guidelines, those are no longer recommended for routine use because there's no real evidence that using those over us doing CPR, there's no real difference in the survival rate. Okay, but where it comes in handy is, and they recommend the use of, is in rural areas, rural, where you don't have the resources or the manpower to do CPR. It also works really well because a Lucas device and not a pulse will generate good CPR compressions while you're moving a patient on a gurney. So whether it's on the ambulance stretcher or on the bed in the hospital, it's going to give better compressions during that time that that gurney is being moved, instead of throwing someone up there, straddling them, trying to do CPR, or trying to do CPR while they're on the cot. Okay, it's not very effective CPR when you're doing it that way. So using a mechanical device such as the Autopulse or the Lucas is a better solution. Also on the back of the ambulance, trying to switch out compressors is very hard to do. Most of you have been in the back of the ambulances. You know, we don't have a lot of room back there. So, all right. Oops. All right. Step one is identifying cardiac arrest and begin resuscitation. Sound familiar? Okay. Recognize that they're in arrest. Shout, tap, check for breathing, check for pulse, begin compressions. Organize the team. Do not delay chest compressions to get everybody figured out. Get someone on chest compressions, okay? Do not move the patient unless necessary, okay? Sometimes it is necessary. If they're on the bed, you're not going to do good compressions on them. Get them on the floor. You're going to have to move them on the bed, out of the chair, out of the vehicle, onto the ground to get good compressions going, okay? Deployment of AED, get it out and ready to go as soon as possible. One provider should be doing compressions while the other provider is getting everything set up. If you're doing the upper left chest and the side, you can actually put the pads on while the person's doing CPR, okay? Might have to have them stop one compression, slap it on, but it shouldn't delay it very long. They can be doing compressions while you're putting the side one on, okay? If responding alone, attach AED first and then start compressions. Getting that shock in is really important to getting that VTAC and that VFib back into a normal sinus. Begin CPR, then attach AED for children and infants. Getting that blood circulating, that oxygen circulating is what's more important for the children than the shock is. Okay. Yeah, I think so. Son of a bitch, I gotta go back. I thought I did I? It says pause recording, so yeah, it's starting. Now I'm gonna have to go in and edit that out, which I don't know how to do. So, okay. So integrated AED, getting compressions while the EMT sets it up. Use AED, turn it on, place pads per manufacturer's recommendation, remove any clothing, jewelry, medication patches, trim excessive hair, wipe away sweat and other liquids, start CPR, analyze, clear patient, and shock if indicated. Sound familiar? Okay. So when you go into your AED station for the practicals, you'll be doing the AED station. Okay, that's all you're going to be concerned about. Okay, still going to say BSI, scene safe, all that, just so you're used to saying it. But when you come into it, tap, begin CPR, AED is going to come in, you're going to attach the pads, all that stuff. Oh. Turn it on. Once advised, press the shock button. Clear everybody. I'm clear, you're clear, everybody clear, clear. Make sure they're clear. Press the shock button. Immediately resume CPR. Okay, there's no wait there. Whoever's doing CPR, in fact, they should be hovering over waiting. Once the shock hits, you're immediately going into CPR again. Okay. Going to reassess every 2 minutes, CPR. I believe this is in your book. So it says it's in your appendix, but if you guys want a copy of it, we'll make a copy of it. Basically, it tells you what steps are: verify the patient is unresponsive, apneic and pulseless. Provider 1 begins CPR. Provider 2 readies AED, turn on AED, bear and prep chest, attach pads, clear patient, analyze. When prompted by AED, shock initiated, verbally clear everybody. Hit the shock button, perform CPR, no ROSC, reanalyze, shock again if indicated.
Did you go over pad placement? It's like it's not that.
Right.
Just as long as they.
I don't know if we've gotten that far yet, but we've talked about up here, down here, right? There's pictures on.
Call. That's
The PD.
yeah, AED pads. All the kind that are connected?
Yeah.
Yeah. Put them right across the way you got.
Okay, cool.
So just don't do that.
Yeah. All right, if no shock indicated, resume CPR immediately. Reanalyze in 2 minutes. Okay. Integrated AED performed through CPR 5 cycles unless patient wakes up, moves, or begins breathing. Follow the AED prompts. Focus on high quality teamwork. Step 3. Integrate additional resources as they arrive. You might be the first ones on there, so it might just be 2 people doing CPR. Once law enforcement gets there, they can start pumping on the chest too, or going to get you stuff. Once fire department gets there, they can start helping out. Get advanced life support coming if as soon as you can, if you have that available. Prepare for next defibrillation. Have someone get your patient history of present illness, how long they've been down, if it was witnessed, if it was unwitnessed. Do your secondary assessment if you get ROSC back. Okay, review physical findings and adjust. All right. Firefighters want to click in on your phone real quick when it comes up. Should family watch the resuscitation? Okay. If the family is there and they are not in the way or hysterical or causing you issues, let them watch. Okay. The reason you let them watch is because it's going to help them it's going to let them know that you're doing everything you can to bring their person back. Okay. So allowing them to watch allows them to get closure. Okay. But again, if they're becoming a problem, if they're getting in the way, screaming hysterically, pulling at you, stuff like that, then yeah, you need to get them out of the way so you can do your job. Okay. Step 4, transitioning resuscitation. Resuscitation is successful, shift to post-arrest care. Get them to the hospital as quickly as you can. Keep an eye on their airway and assess to ALS, access to ALS. So if you're 30 miles away from the nearest hospital or ALS service, get them to rendezvous with you. Glendo is a good example. Glendo has some ALS providers, but most of their providers are BLS. So they usually, if they're closer to us, they'll call us. they're on the other side of the lake, they'll call Wheatland and have them rendezvous. And we usually don't even move the patient. We just jump in with them and then we bring our drugs with us. And then we head to Douglas, or they head to Wheatland. Yep, coal mine's another one. If they have something happening, they're going to pick which direction is quickest to go, and then they're going to head that way. Check pulse every 30 seconds. No pulse is found. Stop the vehicle, start CPR. The AED is not ready. Analyze the rhythm, deliver a shock. Why do we stop the vehicle? Anybody know why?
We think it's safe.
Yeah, so the vibration, they're not running lights and sirens. Okay. The vibration of the road can cause interference with the monitor. So with the AED or this monitor, it'll show something that's not there. So you want to make sure you stop the vehicle. Used to be we stopped it, turned it off, and then resumed whatever we were doing. Okay. Continuous shock separated by 2 minutes of CPR. Yeah, go back right into what you were doing before. Once you start resuscitation, you must continue until spontaneous circulation occurs, then provide rescue breathing as needed. Spontaneous circulation and breathing occur, or another trained rescuer can take over for you. The other way, let me make sure I'm not. Yeah. Either someone else takes over for you, you turn your care over to a person with higher training, so ALS, you're too exhausted to continue, or you receive cease resuscitation order from medical control. So a lot of steps in there as to what you can terminate on. Usually, if you're a BLS crew, what are you going to want to give to your medical control? What information do you think is important for them to know?
How long did they rest?
Yep. Yeah. So if they were in arrest, say you're 20 minutes out when you get the call, okay? Medical dispatch says, hey, I'm going to walk you through the steps of CPR, and the family says, no, we're not comfortable doing that. So it's now 20 minutes for you to get there. It takes you a couple minutes to get in, so we're at 22 minutes from the time the 911 call came in. No CPR has been done. Okay. You begin CPR, you get 4 no shocks. You've been working them for about 20 minutes. Nothing's coming back. ALS is non-existent in your world, so you call medical control, say this guy was down for at least 20 minutes prior to our arrival. No CPR was done. We've had 4 no shocks. At that point in time, your medical control may say, yeah, go ahead and cease efforts at this time. You're probably not going to get that person back, and if you do get them back, the quality of their existence is going to be low. So, and the chance of them making it out of the hospital are pretty low.
How long does it take to rest?
That I can't tell you. I mean, it depends on a lot of circumstances. So, cardiac arrest due to hypothermia. We don't call it until they're warm and dead. They're not dead until they're warm and dead. And that'll be something that we bring up in environmental emergencies. But in that case, you're probably going to transport them in and warm them up. And because a lot of things happen during hypothermic state that the body protects itself. And people have been down for hours and been brought back and no cognitive issues. Normal every day, after 3 minutes, 3 to 5 minutes, your brain isn't going to come back normal. If you get them back after, that 5 to 10 minute mark, they're going to have some cognitive impairment. 15 to 20, you're probably not getting them back with an intact brainstem. So something's going to be terribly wrong with them. So the longer the body goes without oxygen, the worse situation, the worse the recovery is. Make sense? So body can survive 3 to 5 minutes without oxygen, 3 to 5 hours without something. Can't remember what it is now. 3 days without water, 30 days without food, stuff like that. So your body needs that oxygen. After 3 to 5 minutes, you're probably going to start having some dysfunction of the brain. Yeah.
I guess.
That was the wrong one to click in on. All right. All right, death notification. It's probably going to be the hardest thing you have to do in the medical field. Fortunately for you as a BLS provider, you are not going to face this as much as paramedics and doctors and nurses are going to. The known fight in the family of an unsuccessful arrest, resuscitation, be straightforward, use direct language. A lot of times when we're on scene, if we're looking at calling it, I'll go in and tell the family, we have done everything we can. There's nothing the hospital can do more for this person than what we've already done. We are more than happy to transfer him, but at this point in time, he is not coming back. He is dead at this point. And I will use that language. And once you tell them, if you say that there's very little hope or, the outcome won't be good, or you use questionable language that makes it sound like there might be hope, then you're giving them false hope. He is dead at this time. We have no electrical activity. We're not getting any heart rate back with the medications we're given. The hospital is just going to call them when we get in. At this point in time, we'd like to stop. That saves them an ambulance bill, saves them an ER visit. Okay. So allow the family the time with the deceased patient. We do this a lot in the ER. When we call them in there, we'll let the family come back. We'll take as much of the stuff off as we can. There's certain things we can't take off the patient once it's been put on. ET tubes, IV lines. We don't take the IV catheter out. We don't take the ET tube out. We leave those in place. We leave the pads in place because that's all part of now the investigation of law enforcement. Because unless it is in the presence of a doctor that it's called, it is an unwitnessed death. Even if the family members watched him collapse and began immediate CPR on him, it's an unwitnessed death unless it happened in front of the coroner or a doctor. So at that point in time, it becomes an investigation for the coroner and law enforcement. So be straightforward, take time, be patient, let them come in, do their grieving, step out of the room for a while, be there for them, be there to support them as much as you can. Try to not use things of how they feel. Okay? Everybody processes grief differently. We talked about this in the first couple of classes. Yeah, you may have experienced the exact same thing, but your way of grieving is different from everybody else's. So Let them have their time. Just be there for them. Okay. And be yourself to a certain extent. Watch your jokes. So. All right. Special considerations: coordination with others who defibrillate before you arrive. Let the operator of the AED complete the shock before you take over care of the patient. There are AEDs all over the place out in the community. Safeway, I think, has one now since they had their last code. Yeah. I know Peak Fitness has one. All the schools in town have them. Public Works. So there's a lot of AEDs out there. So when you get there, they might already have one on, be doing CPR. If it says shock advised, let them complete their cycle, then take over. Okay. So if they have an AED that's working and you're a basic service, don't switch their AED out for yours. Okay. Just leave theirs on, let it continue doing its job. Don't take the time to take their pads off, put your pads on. It was nice when the PD had the same AED pads as we had, because we could just unplug their AED and plug our monitor in. But now that they've switched AEDs, it's a whole issue of taking stuff off. And if it's just AED, if you're doing basic stuff, just leave their AED on, work with it. Yeah, it's probably going to go to the hospital with you if you get ROSC back. But at that point in time, they're going to come up anyways. So just if it does belong to a private entity like Safeway, Peak Fitness, schools, make sure they get it back. Okay. Follow your local protocols. You're going to see that a lot in here. So, all right, resuscitation in the ambulance. Initial steps of resuscitation in moving vehicle should be avoided. Patient goes into cardiac arrest, stop the vehicle, perform CPR, and deploy the AED. Okay, we already talked about this. The movement of the vehicle can cause false reading on the AED, so you want to make sure you're stopped. Cardiac arrest for hypothermia, submersion.
You can do it.
Yeah, attempt defibrillation once in hypothermic cardiac arrest and then transfer. Core temperature should be at least 86 degrees Fahrenheit before attempting defibrillation again. So at this point in time, you're going to try to defibrillate them once, get them in the ambulance, crank the heat up, get to the hospital, and what they're going to do, passive or aggressive rewarming, depending on what situation calls for. And we don't terminate resuscitation attempts in the field for hypothermic patients. Submersion injuries, patients in cardiac arrest, be aggressive with the airway and rescue breathing. Try and do ventilations, get that air, that water replaced by air. Take precaution to make every defibrillation safe for you and your team. In other words, if you're in a pool of water where you're kneeling in water, the body's in water, get them out of the water. Okay. Get them dried off as best you can, because electricity is going to follow the path of least resistance. And if their whole body's soaked, it's going to just go right across that water into each pad, and it's not even going to go into the body. So make sure you dry them off the best you can, and then place your defibrillation pads and shock from there. If you are in water, this happened to me twice, where we were in enough fluid that when they defibrillated, I felt a tingle. So make sure you're out of it. It's probably not going to send you into arrest, but if you have a heart condition, A little bit of tingling might send you into arrest. Now we got 2 patients. And we just went over that. Don't defibrillate a soaking wet patient. Dry the patient's chest. Move medication patches. So medication patches that are above the pads or in the path of the pads, just go ahead and remove them if you see them. If you don't see them and you defibrillate the patient, they might have a burn mark wherever that patch was. But if that happens, it happens. But try to remove them if you know they're there. Always check the back of the shoulders because a lot of people put patches there. Okay, implant surgeries. You can defibrillate someone with an implanted device. You don't want to put the pad over the top of the device. Okay? If you do that, you're probably going to short the device out. So make sure if you see a little lump underneath the skin or some of the family member says they have a pacemaker, that you find the pacemaker and then place the pads appropriately. If the pad is on the left side where you normally place your device is on the left side where you normally place your pad, go front and back with the pads. That should get it you far enough out of the way of it. Okay. So these are some of the devices you might see. Pacemaker, ICD implanted cardiac defibrillator, ventricular assist device, or an LVAD, cardiac bypass surgery. So cardiac bypass surgery is usually pretty good. It's a big, huge zipper going right down the middle of the chest. Okay. LVAD. Don't remember if they talk about them in this chapter or not. Did Stacy go over them at all last night? All right, so left ventricular assist device, an LVAD, is implanted device. Well, its tubes go in. The machine itself is sometimes out. They wear it in either a vest, or they'll have it on their belt loop someplace. What that device is doing is circulating the blood. Trick to this is you're not going to feel a pulse. Okay? These people walk around with no pulse because this device is pumping blood through the body for them. So you're not getting that beating of the heart that's pumping it. It's just flowing. So with these, you want to be careful. You know, if the person's awake talking to you, you can't find a pulse, ask them, hey, do you have an LVAD? They should be pretty quick to tell you they have one, especially if you're sitting there feeling on the radial and you're not feeling anything. Unless they're just messing with you, they should be going, oh, I have an LVAD, so you're not going to feel it. Okay?
Well, we're gonna have battery pack. On and press this stick. If you have a patient that has an LVAD, maybe they're having open middle status or whatever, you take battery pack with.
Yep. And they usually have multiple batteries on them. The other thing about the LVAD is if they are unconscious and you're not finding a pulse, look for, before you start cutting clothing, look for devices that are hanging on them. Because a lot of times these devices will be underneath the shirt. You start cutting the shirt away and you cut through the line that's going into them. You just cut off their power that's circulating their blood. So you want to be careful with that. All right. Any questions over those? All right. Chapter review. Time is it? 9 o'clock.
You don't have.
My parents put their slip in their home. My sister is deadly sick. I ain't getting sick.
All right. So what are 2 rhythms that are shockable out of those four?
You think it's safe?
Out loud. Right. So asystole, what's it look like on a EKG? Flatline, right? No shock. Pulseless electrical activity, what's going on? There might be a P wave. So, but what's it say up there? Pulseless electrical activity. Right, right. So there's electrical activity, but the pump's broken. So,
Push button always.
yeah.
For us.
Okay, cardiac arrest causes immediate drop in coronary cerebral perfusion. Without immediate care, cells of the heart and brain will die. So what do we need to do? CPR. And what's that do? Circulates the blood. Good. Okay. And what's asphyxia? Suffocating. They're not getting any oxygen, right? So think about it that way: is there's no heart's working, but there's no air going into the system. So should ask that one first. Yeah. All right. So 5 steps. According to the book, there's actually 6 now. So you got recognition and activation of emergency response system, immediate CPR, rapid defibrillation, basic and advanced medical services, advanced life support, and then recovery and post-care. Okay. All right, mechanical CPR devices. What's that? What is that? Lucas? Yep, got a pulse. Okay. Yeah, we beat that one. So how do we clear a patient before administering a shock? Yeah.
Get everyone out of the way.
Yep. I'm clear, you're clear, everybody clear, clear. Old McDonald shocking this guy. Yeah. All right. All right. 78-year-old male has been complaining of severe shortness of breath for 20 minutes prior to your arrival. When you arrive, the patient is unconscious and not moving. What are your immediate priorities? Okay. What's next? Okay. So check for responsiveness. Check for pulse. What else are we checking for? Breathing. Okay. Good. And what's the other one? Airway. Yep. Good. So airway, breathing, circulation on this guy. He's not breathing. What are we going to do? And bag him. Yep. So head tilt, chin lift, bagging. Doesn't have a pulse. What are we going to do? CPR. Good. All right. Good job. All right. Any questions? All right. Roads are shit. Drive safe. Come back Monday.
Well, it's bad, definitely